A hearty good afternoon and welcome to our session on growth problems in pregnancy. We're glad to have Dr. Amita Anderson among us today to help us understand this topic. Growth problems may refer to when a fetus does not grow as expected. Now, there can be a variety of reasons for this underdevelopment, and understanding the gestational age and growth milestones is essential. So don't hesitate to ask questions or clear any doubts with our doctors. Doctor, you have the stage.
Thank you so much. So, good afternoon, everybody. When Apollo Cradle asked me to do a session, I chose growth problems because that is something we come across very, very commonly. We know that a lot of pregnancies, the main concern, or even if things are going good, the first question the patient asks is the baby growing well? So, that is what we are going to talk about today. Is the baby growing well? So before you are welcome to ask questions and put your messages on the chat, and we will try to address all your questions as far as possible. But before we proceed, let me just give you an overview about how we handle the growth problems, how it is recognized, what are the things that we look into, and what commonly causes these problems, and how best can we handle them. So, when we look at a fetus, we look at it at different stages in the pregnancy. So, right at the very beginning, we have something called as an early growth scan, where the focus of the scan is mainly to look for the heartbeat, to see if the pregnancy is implanted well and implanted in the right place, and to make sure there are no additional problems like any bleeding or anything of that sort. During the early pregnancy scan, the most important factor or the most important thing that we do at that stage, besides ensuring that the heartbeat is there, is to date the pregnancy. Now, this dating of the pregnancy at less than 9 weeks of pregnancy forms the baseline. So, we assign a delivery date, or we assign the gestational age of the baby at this stage, because when we assign it early, the variation is very less. So if we say this baby is 6 weeks old, the variation can be as little as 2 or 3 days. Whereas if we assign this gestational age at, say, 19 weeks, then this variation can be as much as 2 weeks. So the baby can be 17 weeks or it can be 21 weeks. The variation is very wide. So we prefer to date the pregnancy very early, and we stick to this dating. So this dating of pregnancy in the early pregnancy forms the baseline. And then moving on, in the first trimester, we have what is called as the NT scan. Now, NT scan is something which has been promoted as the Down syndrome scan, or you call it the screening for chromosomal problems. The important thing about the NT scan in regard to growth scans is, in regard to the growth of the baby, is in addition to looking at the markers for chromosomal problems and looking at the anatomy, development of the organs and other things, is we also look at the flow in the uterine arteries. This blood flow in the uterine arteries gives us an indication as to how well the placenta is developing. Now, placenta is the organ which is going to supply the baby with nutrition, with oxygen, and also take care of the excretory functions of the baby. So this development of the placenta is something that starts very early in pregnancy and goes on till around 22 weeks. So when we look at the placenta at this stage, at say around 12 or 13 weeks of pregnancy, it gives us an indication as to how the blood vessels in the placenta are developing, how well the placenta is developing. So once we do the scan, we combine the scan parameters with a blood test called as a double marker test. In the double marker, we have something called as PAPE. Now, PAPE is a product which is secreted by the placenta, and again, this helps us to assess the placental function. So based on this, we give you a risk assessment for the likelihood of, growth restrictions developing late in pregnancy, or we tell you like there is a risk of the mother developing hypertension later in pregnancy, and based on this risk assessment the mother might be started on ecosprin. So this helps to improve the blood flow and to help gives us a indication as to whether there is a risk or not. So this is what we do in the first trimester. Now, moving on to the second trimester, the first visit will be for the anomaly scan. Now, anomaly scan, as we all know, is the most important scan in the entire pregnancy. This scan is important because it gives us an indication to various things, not just the anomalies or the structures or the organs of the baby, but it also gives us an indication as to how well the placenta has developed, tells us whether the baby is likely to face growth problems. It also gives us indications. There's something called a second trimester assessment for the chromosomal problems, as well as we look at other things like the fluid around the baby and how the placenta looks and a lot of other things. So a second trimester assessment of the uterine arteries is at a point when the formation of the placenta is almost complete. So if at this point we find that the uterine artery flows is not adequate, then it gives us a very high indication that look, this baby might have growth problems later because the supply might not meet the demands of the growing child. So this is an indication that this patient needs monitoring. We need to watch out for growth problems. We need to monitor the blood supply and things like that. So if at this stage, say around 20 weeks, we have a baby which is not growing adequately, we are very concerned. Because in the early pregnancy, most of the growth of the baby is based on the inherent genetic properties of the baby. It is very less influenced by the external factors or the environmental factors or the placental environment, as we can call it. But later in pregnancy, as I was talking about the placental function, all these start playing a role. So if at around 20, 22 weeks, we see a baby which is not growing adequately, we call this as an early onset growth restriction. And here we are very concerned because growth restriction has started at a point where the genetic potential of the baby might be the cause for a low growth. We might be facing something like a viral infection, or there is a possibility that the implantation of the baby is not okay, or the baby itself inherently has an abnormality, which is why the baby is not growing. Like the baby has a heart problem, an abnormality in the heart, or some kind of a syndrome which is causing the baby's growth to be impaired. So there are these kind of problems which take priority at this stage. So if there is a growth problem at the 5th month, we are very concerned. And of course, this in turn results in a lot more detailed investigations that need to be done because we need to look at chromosomes, we need to look at infections, we need to look at the blood flows. So all of this needs to be covered. This is around 20 weeks. So usually after the first trimester scan, the first trimester early pregnancy confirmation, then we have the NT scan or the first trimester screening. Then we have the target scan, which is the anomaly scan. After this, the patient follows up clinically and we look whether the abdomen size is okay, whether the baby is growing satisfactorily clinically. And if things are going well, we would probably see the patient next around 30, 32 weeks, or at the earliest, maybe 28 weeks if we have any kind of doubts. And at this point, the focus completely shifts from looking at the anatomy of the baby. Of course, we do look at anatomy, we do look at organs which are evolving, but the focus shifts onto the growth of the baby. Now, a baby which is growing well within normal centiles, has normal LICA, has a normal blood flow in the umbilical artery Doppler, as well as the uterine artery Doppler, is very reassuring. But babies who are having problems because of improper implantation, improper placental development, might start showing changes at this point. Now, these changes can be very gradual. It can sometimes happen very drastically. So, a baby which was growing around the normal centiles, suddenly the growth starts slowing down. Now, this tells me that for some reason, the baby is not getting the required amount of nutrition, which is why the growth is slowing down. The baby is basically conserving all the energy or the nutrition it is getting for basic life support functions, and the growth is being compromised. So, this is a indication that we need to look into, the blood flows of the baby, see whether the supply coming from the mother is adequate, which means whether the maternal nutrition is adequate, whether the mother is taking a high protein diet, she should be having enough fluids in her daily, whether she's taking enough fluids, whether there is enough the calorie requirement is being met, things like that. And once the mother's nutrition seems all right, we look at the uterine arteries. Now, uterine arteries are supplying the uterus, and is it gives us an idea as to whether there is any other factor like the maternal cardiac function, all these are all right, and whether it is supplying the blood to the baby. In the uterus, the umbilical artery flow. Now, this umbilical artery flow is something that is very, very important to us. When the heart is pumping, the baby is getting blood flow when the heart is pumping, as well as when the baby's heart is relaxing. So we keep following this for whether there is any development of high resistance. If the baby is getting any high resistance in the umbilical artery, it is an indication that the baby's placenta is not able to supply the baby with enough nutrition or enough blood and oxygen. So once this starts happening, we see changes happening in the growth of the baby. And if the baby is, say, around 28 or 30 weeks at this point, our main goal at this point is to take the pregnancy as far as possible, because we don't want to deliver the baby preterm unless we cannot help it. So we want the pregnancy to reach as close to maturity as possible. So we will step up the monitoring, and we will keep looking at the umbilical artery flow, and we also look at other parameters, like we look to see whether the blood flow going to the brain is adequate, whether there is any signs of decreased oxygen supply in the baby. So as long as these things maintain, we try to just keep pushing the pregnancy, monitoring the mother for any development of hypertension. We try to give supplements, and we try to continue the pregnancy. At any point, once the umbilical artery starts showing resistance and the monitoring is stepped up, if at any point we feel that the baby is not getting enough oxygen, by not getting enough oxygen at this point, we mean if the baby is not able to sustain itself, that is, the baby is not able to maintain the normal life functions like the heartbeat, the normal functions of the brain, the kidney, and all of those vital organs. If we are seeing indications that this baby is struggling with even those vital functions, then it becomes an indication for an early delivery. If the baby has crossed 34 weeks, we can reasonably confidently say the baby will be taken care of in the NICU, and most of those babies do well. Between 28 weeks and 34 weeks, it is a little more riskier because we are dealing with the baby who is more immature, more preterm. But again, given the present scenario, given the present facilities, as well as the uh, expertise that is available in our institution now, we are reasonably well able to handle these pregnancies. And even if we do have to deliver a baby which is, say, around 26 weeks or somewhere around that gestational age, most of them are doing very well. And by very well, we mean that the baby goes home at a reasonably good weight without any ill effects or side effects due to the preterm delivery. The babies go well, and after the delivery, If the babies are facing growth problems because of the uterine environment due to the inadequate nutrition or blood supply, they have something what is called as the catch up growth. So as long as the growth in the womb is not because of any other cause, like it is not because of the baby having an infection or having a chromosomal problem or a structural abnormality or something of that sort, these babies after birth generally do very well, and they are able to cope, and they grow and develop on at par with their peers who are born at term and who did not have any growth problems. So, given that, it becomes very important for us to handle these babies very well. Because if the delivery of the baby is not timed well, then the baby in utero can suffer damage due to the baby not having enough oxygen. So, we do not want to push a pregnancy to that stage. We want to deliver the baby before such a compromised stage is reached. So, which is why we try to monitor the baby using the Doppler flows. We have other uh, things that we do, which is called like the biophysical profile, the non stress test. All of these combined give us an indication as to the well being of the baby. So, this is very important. So, overall, the growth of the baby is something that we will follow very, very rigidly. We will, keep a close watch. And one of the major problems that we face is when patients who live in peripheries or patients who have had antenatal care outside, they suddenly land up with us in an emergency. It becomes very difficult when we don't have the previous scans. We don't have a baseline assessment of the gestational age. So then we are forced to go with whatever we are seeing at that point in time. So it is important that the protocols or the follow up plan is made very early. So this planning of the pregnancy scans or following a particular protocol is important. And at each scan, it is also very important that a growth chart is plotted. Normally, when after the birth of the baby, when you go to a pediatric clinic, usually we have the height and weight charts. We have the baby is going to be weighed, the baby is going to be, the height is going to be measured, and they plot it on a graph and then say the baby is growing well, it's underweight, overweight, anything of that sort. The same thing needs to be done for the fetus in utero. The baby in utero behaves very similar to the baby outside with a few variations, of course. So the monitoring needs to be as closely followed as we would for a baby who is outside. Now, are there any? If there are any questions, we'll address that, or we'll go on with a few other scenarios. Okay. So as of now, we don't have any other questions, I think. So coming back to growth problems, right? So another thing that is very closely related to growth problems is the amniotic fluid. So as all our pregnant mothers must have heard their grandparents, their mothers, they will ask about the growth of the baby, and the next question is going to be, is the fluid adequate? Is the waters around the baby adequate? Now, this is something that is very closely linked to the growth of the baby. As long as the baby is growing well and getting a good blood supply, the baby is going to have a good blood supply to the kidneys. Now, the amount of fluid around the baby is very dependent on the amount of urine that the baby is making. More than 90 to 95% of the amniotic fluid is the urine formed by the baby. there is after about 16 weeks of pregnancy, there is very little contribution from the amniotic membranes or from any other source. It is mainly formed by the baby itself. The remaining, other than the urine, we have other secretions into the fluid from when the baby spits out, when the baby breathes, there is pulmonary secretions, there's secretions from the lung which are added to this fluid and things like that. But majority of it is the urine of the baby. So now when we talk about the amount of fluid, and I say that majority of it is the urine of the baby, when a baby is having a growth problem because it is not getting enough nutrition, it's not getting enough oxygen, it's not getting enough blood supply, the amount of blood going to the kidney is reduced because the baby wants to shunt most of that blood which is coming to more important organs like the brain, like the heart, so that it is able to sustain its basic life functions. So that is how it happens even in the later life. If there is any compromise on the amount of blood, it is shunted towards the most important vital organs, whereas the supply to all the other peripheral organs, like the hands, legs, or for the growth of the baby, everything is compromised. So, in turn, the blood flow to the kidneys is reduced. When there is less blood reaching the kidneys, there is less of it filtered, there is less urine formed. So, when we see a patient who says that there is inadequate blood supply, immediately we go back and see whether the blood flow in the umbilical artery is okay, whether the growth of the baby is okay, because these things are linked. Well, of course, if the patient is leaking fluid, or if there is any other problem like the baby is there is a rupture of membranes, or the patient has not been forming the fluid itself, that is a different scenario altogether. So these are the factors which are important and which go hand in hand. So to summarize what we have spoken about so far, we have the various trimesters and how we look at the growth in each of these trimesters. When we see abnormalities very early in the gestational age, that is, if we see a very early pregnancy growth problem, then it indicates that there is something that is very seriously going wrong. Whereas if it is a little later in pregnancy, let's say like around 28 weeks or any time after that, then the focus is more on placental function, whether the baby is getting enough blood supply. And that is the most common scenario that we face. Majority of women who have late onset growth problems is because the uh, blood going through the placenta to the baby is inadequate. And when we are talking about placental function, we need to remember that the placenta is also the structure that is responsible for the mother developing problems like hypertension in pregnancy. There is a condition called as preeclampsia, where the mother develops hypertension, there is loss of protein in the urine, and that can sometimes be a life threatening problem. And this is a scenario which is very closely linked to the placental development as well as the placental function. When a patient is a preeclamptic patient who's having PIH or who's having hypertension in pregnancy, like any other growth problem, it becomes important to monitor the flow of blood to the baby, because here the mother's circulation also starts undergoing changes and the blood supply to the uterus to the baby is reduced. So it is important that the maternal hypertension is very well controlled, because this hypertension is a factor which is directly affecting the amount of blood reaching the baby and which is affecting the circulation. So this it is important that the hypertension is well controlled to improve the outcomes in the fetus. And again, preeclampsia is a condition where it might be necessary to deliver the baby early in view of the maternal condition. So when we are faced with a scenario like that, if the baby has been receiving enough blood flow and the baby is a well grown baby, of course, even if it is a preterm baby, the outcomes are better than if we are having a baby who has not been having enough blood supply, who has been having growth problems, and whose cardiac function is not adequate, or if the brain functions have been deteriorating because of very severe lack of blood supply to the baby. So again, here it is important to time the pregnancy based on the blood supply and the status of the baby. So I think that kind of summarizes the most common issues or the most common problems that we face when it comes to the growth of the baby. And we will be happy to answer any other questions that anybody might have, or you can put them in the chat box. We will try to address them as early as possible.